Welcome everybody. This is Point of Care Ultrasound course. That is a master lecture series. My name is Yash and I have been teaching ultrasound since at least 2007. This is a unified course for everybody including family practice, internal medicine, surgery, anesthesia and ER. Now the need for a unified course is so that everybody learns the same thing and I can keep variance to a minimum and excellence to a maximum. Now, if you are a surgery resident, you could be asking, I just want to do fast. Why do I have to learn basic cardiology views? And the answer to that is that you could want to do a subcostal view in your fast examination only to find that a loop of bowel or pneumomediastinum or pneumoperitoneum or a bandage is in between the view you want and your ultrasound probe. Also, your patient might undergo trauma surgery and then deteriorate later in the ICU or the ward, and you need to know how we use ultrasound to basically enhance our physical examination and get the best out of the situation and get the most information in the least possible time. The part 1, the basics, is prerequisite for this course so that when you come to the sim center, you are ready to actually start using the probes and getting the psychomotor skills necessary to get the best images and the best interpretation. So what is ultrasound? Basically, human beings can hear sounds of a frequency anywhere from 20 to 20,000 cycles per second, also called hertz. Ultrasound, which is sound greater than 20,000 hertz. In medical ultrasound, we use sounds of the frequency of 1 to 10 million cycles per second. So what is sound? Sound is basically a pressure wave. When I am talking to you, my vocal cords are vibrating. That creates a wave of disturbance that travels through air and then hits your eardrum, which also vibrates. And that vibration is registered by your brain as sound. There cannot be sound without vibration. The sounds of the insects in my garden is because of vibration of their wings. The sound of music from your speaker is because of vibration of the diaphragm. In ultrasound, we use piezoelectric crystals to create the vibrations. So what happens in this crystal is that you will have alternating current hit the crystal. When that happens, all the molecules of the crystal change their polarity, and because of that, the crystal changes shape. And that change of shape creates a pressure wave of sound that goes from the crystal in all directions, but the probe has a damper behind, a reflector behind, so the sounds all come out in front of the probe. And the best thing is, when sound hits the piezoelectric crystal, it again changes the molecule's polarity and the crystal changes shape again, but this time it produces alternating current. When people, for example, the folks from Butterfly, tell you that their technology is somehow better or different because they do not use piezoelectric crystals, but they use chip technology. The point is that the chip does not vibrate. The chips are connected to electrodes. The electrodes have metal plates suspended in between. When you give electric current to the electrodes, these metal plates vibrate and produce sound. When sound hits the metal plates, they vibrate and the electrodes then get electricity. It's the same concept, but using metal plates instead of piezoelectric crystals. Let's talk about sound. In any given medium, the sound travels at a constant speed. Air is a bad conductor of sound. Right now, you are listening to this lecture. If you keep walking away from here, there will come a point where you don't hear me anymore. And the reason is that over about 200 wavelengths, the pressure wave dissipates because it gets scattered by the molecules in air. Now, if you have seen old movies where the cowboys are trying to rob a train, even before hearing the train come in, somebody puts their ear onto the steel railing and hears the train about half an hour to 1 hour before you actually hear the sound or the whistle of the train engine. So the higher the density, the faster the sound travels, but all sound dissipates over time. Now the speed of sound, again, is different in air and different in water. It's higher in water, it's faster in water. And therefore, whales, for example, could talk to each other 3,000 kilometers apart, so that a whale on one side of the Atlantic Ocean could basically tell a whale on the other side of the Atlantic Ocean when and where they should meet for a date. Alright? So the speed is equal to frequency into wavelength. So what does that mean? It means that if I have a high frequency crystal, the wavelength has to be small, so that in any second, the sound is traveling at the same speed. If I have a low frequency transmitter, then it has to have a longer wavelength, so that again, over the same time, sound travels the same distance in a given medium. Why do we need ultrasound millions of hertz a second? Is because if there are 2 points in a tissue and I want to distinguish these 2 points on my screen as 2 separate points, then the wavelength of the sound that has to interact with these points should be somewhat of the same distance between these 2 points. So if I have a high frequency probe, there you go, interaction here, I will see these 2 points as 2 separate points. On the other hand, if I use a higher frequency probe, it might either completely miss these 2 points, or you will see these 2 points as one. You won't be able to distinguish between them. So therefore, if I use a higher frequency probe, I get a higher resolution image. And if I use a lower frequency probe, I get a lower resolution image. Now you would say, why would you ever want a low resolution image when you can get a higher resolution image? And the answer to that is what I said before. After about 200 wavelengths, the sound energy is almost gone. So that means if I use a high frequency probe, yes, I will get a high resolution image, but after 200 wavelengths, I'm done. So therefore, these high frequency probes can only see tissue 1 to 6 centimeters in depth. Now, if I want to see the heart, or if I want to see the liver, or the kidneys in the back, or a baby, or the uterus, or the gallbladder, etc., etc., I need to go deeper. and therefore the 200 waves need to be of a bigger wavelength. So although I get a low resolution image, I can actually image up to 10 to 20 centimeters in depth. And therefore, if I have to see the big organs, I use a low frequency, high penetration, low resolution probe. And if I want to see my needle hitting a nerve or my needle hitting a blood vessel with accuracy, I need to use a high frequency, high resolution, but low penetration probe. The ultrasound probes that you will most commonly use are linear, curvilinear, and phased array. Now what happens? In a linear probe, what you have is 256 to 512 crystals arranged in a single line. These are of 7 to 12 megahertz and they can go 1 to 6 centimeter in depth. Not only can they distinguish between two separate points that are in line with the probe, but because of the density of crystals, they can also do a good lateral resolution between two points separated laterally from each other, where the points will be close, but you can still distinguish them as two separate points. Now, one thing about the linear probe that everybody needs to understand is that if you look at it in a lateral profile, okay, sideways, the ultrasound beam that is emitting from it and coming back is the thickness of a credit card. And therefore, if you have a needle approaching this ultrasound and you think you should be seeing the needle because it is crossing the boundary of the casing of this piezoelectric crystal ultrasound probe, you will see nothing because you have not yet touched this ultrasound beam. The ultrasound will only see an object if the sound beams hit the object, get reflected back, and then hit the piezoelectric crystal again, which generates an alternate current, which then is registered as a point or a pixel on the screen. Even here, the needle is almost midline, but it is still not touching the beam. Now, what you can do here, you can always tilt your ultrasound so that the beam now touches this image. But until you do that, you are going to see nothing. Now, at this point, the needle has actually crossed the center line of your ultrasound probe, and sound waves come down and get reflected back, and you see a point. If the needle crosses this line, you will still only see a point. Why? Because the ultrasound will only register images along this beam of a width of approximately a credit card. Now, if you are doing a inline view, again, the needle is approaching the ultrasound and it has definitely crossed the casing. But you see nothing because it has not yet crossed the ultrasound beams. Only when it actually crosses the beams that you get reflections of the needle and you see the needle here in your screen sideways. The curvilinear probe is designed to give a big view of big organs, including the spleen and the liver and the kidney behind it, the uterus, the aorta, so on and so forth. Here we are not looking for lateral resolution or axial resolution because these are big organs. We are not looking at really small points. So you have somewhere around 128 to 256 crystals. These are low frequency 2 to 5 megahertz, high penetration, low resolution, and this can go to 10 to 20 centimeter in depth. And these images are fatter because the crystals are sometimes arranged in more than one line. The phase array probe is designed for cardiologists and is their favorite because guess what? People have ribs, and these ribs have hardly a centimeter between them, and the heart is protected by the rib cage. So if I have to look at the heart, I need a probe with a footprint which is small enough to actually fit in the space between the ribs, but by electronically steering these 64 to 128 crystals from one side to another, I can get an image which is bigger, and then you can see the whole heart in between there. Okay? These are 1 to 3 megahertz, and they sweep to create a bigger image than the footprint of the probe. So how does an ultrasound actually create an image? And it's the same concept as you have in a boat when you are using a fish finder. So here's your boat, there is the fish finder, it gives out a sound. And the sound can travel through water and hit the bottom of your river, creek, lake and come back. And by the amount of time it takes for the sound to go and come back, it registers a depth. Now imagine later on another sound comes in and then it gets reflected faster. That means it hits something here. And then maybe another sound will hit something here, sound will hit something here, and very soon you realize that you might be looking at a big fish. On the other hand, you might have a sound here, a sound hit here, sound hit from here, and you might realize you are looking at a sunken submarine. Water has a constant speed of sound, so by looking at the amount of time, distance can be calculated. In the human body, the lungs are made up of air, mostly, and air is a bad propagator of sound, so the velocity in the lungs would be only 600 meters per second. On the other hand, water and blood really transmit sounds really fast, so the velocity is faster. And bone, of course, will reflect most of the sound at a very high speed, and so on and so forth. It seems that the mean propagation velocity of sound in human tissue is 1540 meters per second. So a piezoelectric crystal gives out a burst of ultrasound, maybe 1 microsecond, and then it waits for the time that it takes sound to go to the farthest reaches of the depth that you have selected and come back. And in between, if it hits something and bounces back earlier, the computer registers that point depending on the amount of time taken. Divided by 2 is the amount of time taken to hit the spot, and then you use this to figure out where that spot should lie in your image. The more reflection, the more a sound is reflected from an object, the brighter it is, and the less a sound is reflected, the darker it is. Therefore, if you look at the pleural effusions or a cyst, the fluid inside it has nothing to reflect sound back on. All sound just passes really fast through it, and therefore it will be black. On the other hand, bone and needle will reflect almost every sound that hits it, and so these will be bright. And everything else is a grayscale in between, depending on how much the tissue density is and how much sound it can reflect. So what happens is that if sound is traveling through tissue of the same density, for example, this is a guy with skin and fat here, so sound comes in, and every now and then a little bit of it is reflected at the same rate, and therefore this fat will be of a light gray color, just like it is expected. Then you have diaphragm, which is a dense tissue. And when the sound hits the diaphragm, because of the difference in tissue density between the fat and the diaphragm, a lot of sound is reflected back. And therefore, the diaphragm will be bright white. Now, some sound will still penetrate, and when it hits the lung above the diaphragm, the molecules just scatter everything, and therefore, all you will see is a white image of everything just scattering back. Okay? That's how ultrasound produces the image. It spends more time listening, about 99% of the time, than actually firing when you look at every individual piezoelectric crystal. Now, one thing is important. Here you have a needle which is coming at a very sharp angle. Okay? And because the needle is metal, it will really reflect sound. But what is happening is sound comes and hits the needle, and then because of the fact that the needle is really reflective, it reflects at a 90-degree angle and you won't see the needle. Why won't you see the needle? Because again, in order to generate an image, the sound has to come back and hit a piezoelectric crystal. If it doesn't do that, it will not register an image. And therefore, in normal ultrasound, in order to get the best image possible, you can do two things. Either you can have the needle come at more shallower angle, or you might push the probe down in a way that the probe is more like this. And now ultrasound will come from a piezoelectric crystal, will hit the needle, and will come back and be registered, and suddenly you are seeing the needle. So therefore, the best images happen when the beam is crossing the structure that you want to image at 90-degree angle. Okay? And of course, if you have something that you want to image which is within 6 centimeters of the skin, you want to use the highest frequency probe and get the best images. So the probe that you are using, the transducer that you are using, depends on the depth of the target organ that you want to image. Alright, now let's talk about amplitude. So, pitch is frequency. Alright? When you have a mosquito in your ear and it produces a high pitch, it's very irritating. But it's a high pitch sound, but not a high amplitude sound, because guess what? Somebody just 10 feet from you might not be hearing that mosquito. So amplitude is volume. When you put up the volume on your speaker, that's amplitude. And why is that important? So you can change the amplitude by changing the amount of current that a crystal gets, or changing the sensitivity of that crystal to the sound that comes back. And that is important because if you have a ultrasound beam, go 5, 10, 15, 16, 17 centimeters and back. By the time it comes back, getting reflected through all the tissue, it might just peter out and you don't get any image. So in order to improve the imaging of organs that or structures that are far away from you, you might want to increase the gain of this area so that the sound coming back from here is amplified and can get registered by the piezoelectric crystal. If the gain is just right, then the cardiac wall, for example, would be a darkish gray, and the fluid inside the atria and the ventricles would be black. If the fluid inside the atria or the ventricles is whitish or grayish, then the gain is too much. You are too sensitive. And if the muscle starts getting black and you can't see the structures, then the gain is too low. You are not sensitive. So that's how gain works. Gain is amplitude. Okay. So now let's see an ultrasound image to see how it really works in real life. Okay, so you have piezoelectric crystals lined up. This is obviously a linear kind of image. The liver is made up of homogeneous tissue, so at a constant rate there is reflection from different areas, and here you have a homogeneous gray. What is happening here? The liver tissue reflects some, and then the gallbladder comes and boom, all sound just travels through, no reflection, so it is dark. When it reaches the other end, the density difference between this fluid and the tissue behind it is so much that a lot of reflection happens just because of the difference in the density of the two tissue, and therefore there is nothing wrong with the posterior gallbladder wall. This is called acoustic enhancement, an increase in reflection just because of difference in the density of this fluid and the tissue behind it. What is happening here? Ultrasound waves come down, some of them are reflected, homogeneous gray, then they enter fluid, it comes straight off, and then there is a full stop because there is a gallstone with calcium in it. Everything gets reflected. This is big time reflection. If everything gets reflected and no sound gets penetrated, then there will be no echoes coming back from this area. And therefore, what you have is an area where nothing is coming back, and so no image is registered, and this is acoustic shadowing. You will also see it in when you are looking at ribs. You will see it when you are looking at vertebrae. Another artifact is the mirroring artifact. So what happens here? There is fat, and then in the fat there is a cyst. There is a lot of difference between this fat tissue and the density of the fluid in the cyst here, and it has a wall. And this wall basically has many different angles. Okay? So a piezoelectric crystal sends a wave out, and because of the fact that this is such a thick wall, such a tissue difference, a lot of it gets reflected at 90 degrees from the wall and goes and hits the crystal here. Now, since ultrasound beams travel in a straight line, these crystals here will think that the sound that they are getting back is coming from straight down. And because of the difference in the time that this guy fired and this guy heard, it will calculate this distance to be from here and will register a point somewhere along this line. And it might register this point somewhere along this line and this point somewhere along this line, and therefore a mirror image is created. The best way to understand this is that if you have shot a handgun with both eyes open, like you should because you want to know what's going around you, then you see two guns. The dominant eye will show you a picture of a gun which is solid, and the other picture looks like a hazy picture of a gun. And a shooter will know how to distinguish between the two images and which images to trust to form a sight. So that is mirroring or refraction. When people were starting to image the lungs, radiologists basically told pulmonologists that you cannot ultrasound the lungs because the air molecules in the lungs simply scatter the images away, and therefore the lung is an organ that cannot be ultrasounded. In 1990, Dr. Lichtenstein then said, so if I see a normal lung with an ultrasound, I see nothing. That means if I see something, there is a problem. So the lung ultrasonography is basically made on lung artifacts. Lungs just give you artifact. You never really see real lungs. Okay? We will come to that in our course, but right now I want to have you understand how some of these artifacts are created. Okay? So here is a picture of the lung. All right? That's a rib. No matter how big a person is, how muscular a person is, there is no fat or muscle between the rib and the pleura. So once you see the rib, this is the rib. Everything, it is made up of bone, so everything gets reflected. So you have a shadow, an acoustic shadow below that. And then you see another rib, and there is an acoustic shadow below that. The first shiny line, about 0.5 to 1 centimeter below the rib surface, below this surface, is the pleural line. Okay? And below that is air. Everything gets scattered, everything gets reflected, not only because air is a bad transmitter of sound, but also because of the tissue difference in the skin and the muscle and the lighter air below the pleura. So what happens is a wave comes out of a piezoelectric crystal, goes through the tissue, some is reflected, hits the pleura and everything is reflected. That's fine. You get a pleural line. The amount of reflection is so rapid and so much in intensity that sometimes a wave comes out of a piezoelectric crystal, gets reflected all over from the pleura, hits the casing of your probe, gets reflected down again, and then gets reflected from the pleura and comes back and hits a piezoelectric crystal. Again, because the crystals don't realize this is happening, and the amount of time taken for this wave is double the amount of time taken normally, this piezoelectric crystal right here will think that this sound came from double the distance. And if it happens 3 times, okay, it will think it has come from triple the distance. So what you have is, if you can imagine the distance between the probe and the first pleural line, you have these lighter reflections in the same distance, same distance, same distance. You have lighter and lighter reflections of the pleura. This is not the lung. This is an artifact, the A-line artifact. Similarly, there is a B-line artifact. And what is happening here is that you look at a rib shadow. So that's definitely a rib. It has a rib shadow. That's another rib. It also has a rib shadow. So that means that this shiny line below 0.5 to 1 centimeter below the rib shadow line is the pleura. And below the pleura, we are looking at something. We are looking at these vertical lines that look like lung rockets. They start from the pleura, not above it, not below it. They continue as far as the eye can see, no matter what the depth of the ultrasound, these continue. They erase all A lines and they continue to get wider and wider. If you have a sick patient, of course all our patients are sick and they are lying down in the ICU, you will get 1 or 2 lines in the bases of the lungs because of atelectasis. But more than 3 lines, bilateral lines, lines that have come to the anterior or lateral surfaces, are usually pulmonary edema, especially if they were not there before you started giving fluid. So if I start giving fluid and I see this B lines, that means pulmonary edema is waiting to happen. These B lines can be unilateral in case of a pneumonia. These B lines can be spaced far apart, okay, in case of interstitial fibrosis. But lung rockets that were not there before you gave fluid and now they are there after you are giving fluid means pulmonary edema is about to happen. So what is happening out here? In the normal lung, which is 90% air, the tissue that surrounds the alveoli is very, very thin. It is so thin that it is difficult to distinguish it from the air it contains. Okay? Before the chest x-ray or your physical examination detects crackles or chest x-ray shows um, uh, pulmonary edema, curly B lines, before the CT scan starts showing ground glass abnormality because of pulmonary edema, what will happen is as you approach the flat part of the Frank-Starling curve, fluid will start collecting in the lymphatics and the interstitium, and the interstitium will start becoming thicker. Now there is a big difference between the density of the air in the alveoli and the acini, etc., and the air and the tissue surrounding it. And this is at different angles. Now we are ripe for all kinds of reflection to happen. Okay, all kinds of reflection to happen before the sound beam reaches back to the ultrasound probe, the piezoelectric crystal. And it is these reflections, these crazy reflections happening that create this artifact of B lines. Okay? Good. Now, rule number 1 that we learned is that in normal ultrasound imaging, the more you are at 90 degrees to the structure that you are trying to image, the better the image because more reflection will reach the piezoelectric crystals. And the frequency of the probe should be the highest frequency possible for the depth that you want to image to get the best resolution. That's rule number 2. Rule number 3 is frame rate. Alright? So what happens is, especially if you're using a sector or a phased array probe, every time a piezoelectric crystal generates a sound, boom, it waits for about 1 to 2 times the amount of seconds or microseconds it would take for sound to travel to the deepest depths of the depth of your sector image, and you choose the depth and come back. Okay? Then it steers and sends another one. And then it steers and sends another one. And then it continues to do that until a whole sector image is created. Okay? So in order to have a frame, you get an image and then it starts doing it again. And then it starts doing it again. So one image is created over some time. Now if your heart or the valves or anything is moving faster than your frame rate, okay, your frame repetition rate or your, the frame change rate, okay, what will happen? You won't see the movement. And that is the exact same thing that happens when you look at a car and you see that the car tires, a car is going forward, but you feel that the tires are going backwards. And that is because the rotation rate of the tire has exceeded the frame rate of your retina. And therefore, before the tire comes back full resolution, you actually catch it when it has already done more than that. Okay? So it actually looks like the tire is going backwards because you are not catching the full movement, and therefore the rule is that you should keep your depth, okay, you should keep your depth the lowest possible depth to see all the structures that you need to see. So use the highest frequency for your depth. You use 90 degrees, as much as 90 degrees as possible to get the best reflection, best images, and you use the lowest depth possible to see the organ that you are interested in seeing. Okay. Now let's go to M mode. Okay. So what happens in M mode? I have an image and then I have a line. And this line, I can shift it right, I can shift it left, I can put this line anywhere on the image I want. But the crystal which is sending image on this line of your ultrasound, is the only crystal that keeps firing and receiving images only across this line. That's it. Okay. So what you are looking at here is a parasternal short axis view. So this is your left ventricle. These are the papillary muscles. This is the outer wall of the left ventricle. This is the right ventricle, and so on and so forth. Now in systole, this will contract, and in diastole, this will expand. But you are actually looking at motion only along this line. Okay? And over time, so this is this line moving over time. Okay? And now there is some guesstimation to take place. So let's see the anterior wall of your left ventricle is around 1, 2, 3, 4, 5. This is 5, 6, 7 centimeters. So let's look at 1, 2, 3, 4, 5, 6, 7 centimeters. So I'm thinking that this is then the anterior wall of your left ventricle. Okay? The posterior wall is somewhere around 10. Okay? So 5, 6, 7, 8, 9, 10. So that has to be the posterior wall of the left ventricle. Okay? And then the papillary muscle must be coming in and out slowly. And this is at around half midway between that. So this reflection is the papillary muscle. Okay? Now I can use this to know that in diastole it is 1, 2, 3, 4 centimeters, and in systole the left ventricle is about 1, 2, 3 centimeters. Okay? This is fractional shortening, and if the fractional shortening is 30 to 45%, then you have a normal ejection fraction. So this is how we use M mode. Now let's go to Doppler imaging. Doppler imaging is very interesting. When you are at the side of a racetrack and you are hearing the cars or the motorcycles come through, so you will hear something like, what is happening? The pitch or the frequency of the sound hitting your ears changes. As the motorcycle or car comes near you, the frequency is increasing, and as the car is going away from you, the frequency is decreasing. And why would that happen? That happens simply because if we can imagine that this is a blood vessel and the direction of blood flow is here. Okay? So if you have the ultrasound and it transmits a wave, okay, and it transmits a sound, and the sound hits a, it is better, let me explain it this way. It will be better, I think. Okay? Let's say you have an ultrasound which is right in the vessel. Okay? It transmits a sound at a certain pulse. That means at the same time, it is going boom, 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 boom. Okay? So a sound wave comes out and it hits a red blood cell and then it is reflected back. Okay? That's good. Another sound wave comes out, but this time the RBC has moved farther away. So now this sound does not come back at the same rate as the one before. This takes longer to come back. And then another sound is emitted, and this time the RBC is even farther off, and therefore the sound coming back takes even longer. So for the ultrasound piezoelectric crystal here, it will seem like the frequency is decreasing. And if you do the opposite, it will seem like the frequency is increasing. Okay? Now, if the direction of blood flow is here, if the direction of blood flow is in this direction and your ultrasound probe is facing this way, then the color of this image will appear red. Why? Because the blood flow is towards your ultrasound probe. Okay? Now, if I have to shift the ultrasound probe so that it now faces this way, then the blood is actually going probe blue. And if the ultrasound probe is exactly at 90 degrees, like I told you, the best view is at 90 degrees, it will be colorless. Why? Because the red blood cells are just there and they are passing through every now and then. But they are neither coming towards nor going away from the probe. Therefore, in Doppler ultrasound, Therefore, in Doppler ultrasound imaging, you do the exact opposite. You would want your transducer to be as much aligned with the direction of flow that you want to study. If you are at 90 degrees, you won't catch it. You have to be as close to 0 degrees as possible to the direction of flow. There are various kinds of Doppler imaging. One of them is called pulse wave Doppler. In my sector, I have a line and I can choose that line to be anywhere. But whenever I have chosen a line, a single piezoelectric crystal emits sound at a certain frequency and listens for sound that is coming back. A single crystal in a single line. Now I have here a box, and even that box can be moved up or down that line. When listening, the crystal will only listen for sound that come back in the amount of time it takes for a wave to go here and back. That means it is not listening to any other sounds, it is simply erasing them, not listening to any other sounds but the sounds that are coming from this particular box. Now this box is on an apical 4-chamber view and it is looking at the mitral valve. So in the mitral valve, blood should go from the left atrium to the left ventricle if everything is okay. This pulse wave Doppler will look like this. The blood that is coming towards the probe will be over that line. And if there was regurgitation, it would be under that line. Blood flowing away is under the line. Blood flowing towards is over the line. Okay? Now, because of the fact that there is a frame rate involved, if the velocity of the blood coming through is too high, then you will have the same effect as looking at a tire go backwards when the car is moving forwards. And what that looks like, which is called aliasing, is that you will have this wave cut off. Okay? And because of reversal from aliasing, you'll have the rest of the wave here. So this part out here, okay, this part out here gets cut off and you see it in the opposite direction. Don't get fooled by that. That is called aliasing. In a color Doppler, you are doing the same thing, except now your box is a little bigger and you are seeing the flow as color. Okay. Now this box can be made small, it can be made wide, it can be made short. I would keep the box as small as possible because unlike the pulse wave Doppler, it is not just a single line looking at a single box. It is a whole lot of lines looking at a bigger box. A lot of computation of different velocities has to take place, and if you overwhelm the computing power of your ultrasound unit, then you will have the same thing aliasing, where in a sea of blue you might see something which is bright yellow. It is the same thing what is happening with aliasing. You are looking at backward flow when none exists. But again, anything that flows towards the probe is going to be red. Anything that flows away from the probe is going to be blue. You will see this in the side of your screen, so there should be no reason for anybody to get confused. The last thing is continuous wave Doppler. And the benefit of continuous wave Doppler is that it does not have the aliasing effect. Here what is happening, it is very interesting. You choose a line, you choose any line. You can put the line anywhere, okay? So you choose the line, and now there are two crystals. There are two crystals. One crystal is continuously firing and another crystal beside it is continuously listening for whatever comes back along that line. So anything that is moving along that line, it will register the highest frequency. So that means that if there are two valves in a row, one valve is open and one valve is stenotic. And the velocity from this valve is smaller. It's open. And the velocity from this stenotic valve is way higher. Okay? Or it could be the opposite. The stenotic valve could be first, the open valve later. Same thing, because it is looking at all the velocities. Again, the stenotic valve will have a higher velocity and the open valve will have a lower velocity. You can see different shading, but you are basically looking at the highest velocity in that line. And therefore, just like we did with the M mode, the motion mode, you have to judge where this velocity is coming from. And of course, if there is a stenotic valve, you would think that that is what this velocity is from. Again, this is tricuspid regurgitation. That is why it is below the line. Any blood flow coming towards the probe will be above the line. Thank you. Look at this video again and again so that once you come for the practical, we can simply start doing our psychomotor skills to get the various images, and you are very clear about the basics of ultrasound. Thank you.